do based on 1,000 patients with cancer and compare how they do based on intervention, the problem is, or the good part is, transplantation wins hands down. And Dr. Yao will show you more of this. If we try to resect the tumors, the patients do okay, but their tumors come back. If we do no surgery, we're talking about, we know what will happen with the natural history of the disease. What the challenge is to find a way to actually select out those patients who won't get recurrent disease. And what this slide is a bone marrow of a patient who has a liver cancer, looking for these cells, which are metastatic cells from the liver. And this tells us that we're going to have a bad prognosis regardless of what we do. So it's very important for us to try to figure out which patients are going to do well with resection, which patients actually have to go right to transplant, and which patients we have to think about another treatment altogether. So with fulminant liver failure, we have to make sure that the patient's brains don't swell. So we actually dialyze the patients. We may put them in a coma to try to rest their brains. And we use hyperventilation, which is a technique of ventilatory support on a respirator that actually prevents the brains from swelling. These patients also have a high incidence of infection that we've got to be concerned about. Now, I told you that we distribute organs based on the MELD, and the MELD is a way to kind of categorize how sick a patient is. So the higher the MELD, the more sick you are, and the more likely you are to die. And so we want to give livers to the people who are the sickest. So the MELD is determined by the creatinine, the clotting studies, and the bilirubin. Now, patients who have cancer actually get a modified MELD, and Dr. Yao will talk to you about that. Now, you all know that all donors are not exactly the same. So a 20-year-old donor happens to be better than a donor my age. That's just reality. So another way to look at it is to say maybe we should give younger organs to younger patients, somebody who's going to potentially benefit more, but we haven't even gone there in liver transplant. And what we do is just give the liver to the patient with the highest MELD. And this slide shows you what happens, your likelihood of dying based on your MELD. So before transplant, that's this column right here, if you got, for 1,000 patient years, if you got a low MELD, 6 to 11, you have a very low chance of dying. However, if your MELD is 40, look how high your chance of dying is. So these are the patients we are trying to serve with cadaveric transplants. Now you can see that the sicker patients don't do that much worse after transplant. It's very surprising. They only do a little bit worse than patients with low MELDs. So once we get patients to transplant, and once you get them to the surgeons, we can really do good work on the patients. Okay, so the problem, of course, is that there are many, many, many people who are waiting for livers and who are on the transplant list, and there's actually not enough donors to go around. So each year, 10% of the patients who are waiting, who are listed for transplant, die waiting for transplant. And in our own institution in 2009, 95 people died. And our hepatologists can take care of patients as better, I think, than anybody in the country. And despite that, 10%, a little bit more than 10% of our patients died waiting. So this is the list, the wait list per year. These are the transplants, and you can see this big disparity. Now, this is a cartoon of the liver, and the wonderful, cool thing about it was an observation made by an anatomist in the early 1900s. A guy named Cunard found out that you could actually separate the liver into different segments based on its blood supply. And the reason this is so cool and wonderful is that you can actually take off this portion of the liver, and this is a separate unit with an artery and a vein and a portal vein, and you can transplant that little piece of liver. Or if somebody's got a cancer in that part of the liver, you can take out that piece of liver and the liver will grow back there. And of course that is Prometheus. So the observation by Cunard allows us to do a number of great things. It allows us to do liver resections safely, because it means the liver will grow back. It allows us to take off a portion of the liver for a child, for a live donor liver transplant, adult to child. It allows us to take off a big portion of the liver for an adult to adult transplant. And it allows us to take this whole liver from a cadaver and cut it in two for two different patients. So it's really great and potentially helps that giant problem that we have with the disparity. So this is a cartoon of how we actually prepare a liver, how we approach a donor for a right hepatectomy, a right-sided liver removal for a live donor liver transplant. And here's a, I knew you'd love this. This is a photograph in the operating room of the donor after they donated the whole right lobe. This is what's left. So if we go back here, this is what's left after we've taken out the whole right lobe to give to another adult recipient. And of course, you know that that's my job, that's the job that I get to do now, the live donor removal. So what they do in Korea is remarkable. They take a left lobe, they take two donors, and they take two left lobes from two donors, or a left lobe and a right donor from and a right lobe from a donor, and they use the two donors for a single recipient. Now you may say, why would they do that? That's a little bit crazy. That potentially puts 3 people at risk instead of just 2 people, and that's true. This is the national data. This is the UNOS data looking at the outcome, and don't forget this is 65 here, it's not 0 here, looking at the outcome of both patient survival and graft survival for both deceased donor and living donor. And I think you got a hint of it a few slides ago, that living donor outcome is actually better than deceased donor. So it's not just that you can transplant earlier when the patients are a little bit healthier, the patients actually do better. This is national data where there were over 2,000 adult-to-adult live donor liver transplants, and we are part of a group that studies the outcome in both the donors and the recipients. But you can see that only a handful of centers have a lot of experience doing live donor liver transplant. And when you look at the outcome from these centers, the more you do, the better you get. So it's really, really, really important to think about that when patients are referred for live donor liver transplant. It has to be done at a center that has a lot of experience, because things can go wrong. Our own program has done more than 216 live liver donors, mostly to adults, but a good number of children as well. And this is the outcome for the first 120 adult patients, and you can see at more than 4 years, really great outcome in the recipients. This is recipient outcome. And this is the pediatric outcome. Our pediatric program is older than the adult program, with about 82% 8-year survival. Now this is the problem. There was an individual in New York who gave his right lobe to his brother. The recipient was a doctor. The donor was a reporter. And the recipient did fine. The donor, however, died 3 days after donating his liver, and his wife tried to shut down every live donor liver program, every liver transplant program in the United States, despite the fact that she had heard about the possibility of death being a complication. So here's the worldwide donor risk. Obviously, the risk of giving a right lobe, the bigger piece of liver, is thought to be greater than the risk of giving a left lobe, and it's about tenfold the risk of giving a kidney transplant. Now there have been 21 donor deaths in the world, and that is a serious potential complication. Now, the Japanese have asked their donors how they felt about donating, and I thought maybe you'd like to see this data. And of course, the issue of being satisfied really relates to how well the recipient does, just as you might expect, because all the folks in Japan who are donating to spouses or to relatives. And we're so invested in, of course, what happens to our recipient that, that really colors how we feel about the experience. Now, I'm showing this slide to let you know that we really don't know what the long-term effects are going to be. You saw our data for adult patients where we had 4-year survival, but we really need to follow the donors and the recipients out 10 and 15 and 20 years before we can feel comfortable. Our program here liver program here started in 1988, so we have a lot of experience. Our adult program is our living program is much younger, and we don't have the experience. But this is a CT scan of a donor, and this is a normal, beautiful liver all the way out to the edge. The spleen is normal size, and you can imagine that when I do this operation, this is how much liver we're going to give away to the recipient. This is a right lobe donor. But look at the same patient a few months later. The liver mass is actually the same as it was before, but the liver is grown in a different place. It's grown all the way over here, and this space is filled up with bowel. The bowel just lifts up, and what this liver is doing is squishing the stomach. So all of my recipients, all of my donors who give the right lobe lose a little bit of weight because they feel full whenever they eat. No, it's true. It's true. Here's some future directions for transplant. You know that we're genetically relatively close to the baboons. The baboons also are resistant to HIV and hepatitis B. So wouldn't they make wonderful donors for livers? If you're an animal rights individual, it doesn't sound so great. This is a photograph. There have been 2 baboon to human liver transplants, both done by Dr. Starzl at the University of Pittsburgh. Neither one of them worked. Dr. Starzl thought he was going to cure HIV disease in recipients, and he did not do that. But it was a yeoman's try anyway. And this is an actual photograph of that transplant. Maybe more promising is the notion of using genetically engineered pigs whose livers may have function quite similar to ours, and whose cells could be changed, genetically engineered in a way so that we don't recognize them as foreign. And people in general are much less attached to pigs than they are to baboons. I mean, in general. So that's the end of my discussion. It was a pleasure to address you. I'll answer your questions later, and we're going to give Dr. Yao an opportunity now.